So our final speaker today is Cheryl Garganta from Tufts University, and she's going to talk about newborn screening, past, present, and future.
Okay, I'm not a mass spectrometrist by birth. It's all stuff I've learned. I'm actually a pediatrician and a biochemical geneticist, so this is a lot of what I've learned on the job. Newborn screening is just what it sounds like. You're testing asymptomatic infants for disease, and the goal is really to start treatment before you have irreversible damage from whatever condition we're talking about. And when we say newborns, typically that means less than a month of age, but that ideally is before they go home from the hospital. If you're going to use a screening test, you have to have a test that's acceptable to people. They're not going to do it if they don't like having to have it done. Look how well people have taken up colonoscopy. It has to be a well-defined disorder with significant health issues. It doesn't matter if you test for a condition if people don't get sick because of it. You need to have a diagnostic test afterwards to evaluate your positive screens. It's very easy to think about these as, oh, yes, this kid has this. But these are screening tests, and so you need to be able to show that, yes, it's true. You need a treatment, and you need to have proof that early treatment improves outcome. And with newborn screening, it first started with PKU. And what I've shown here is the phenylalanine is converted to tyrosine by the enzyme phenylalanine hydroxylase. And if you have PKU, you actually have a deficiency of the phenylalanine hydroxylase. So you have very low tyrosine, you have very high phenylalanine, and the phenylalanine is also converted to phenylpyruvic acid. And that's the compound that came up in the tests in the 1930s where they first discovered what was causing PKU in folks with intellectual disability in institutions. What happens is if you don't treat reduce the blood phenylalanine, you end up with severe intellectual disability with the average IQ of around 10, autistic features and some eczema, and because you've got a deficiency of tyrosine, you get lighter pigmentation. Our treatment is to use a phenylalanine-restricted diet. And initially, this was a formula that was made of amino acids, sugar, and oil. And it had to be concocted daily. Now we've got recipes that are already come in a can, just like any other formula. If you over-restrict the phenylalanine, you get poor growth. And so you do need to test and make sure you're providing some phenylalanine because it's an essential amino acid. In the 50s, they tried this treatment, and what they found was that the behavior got better in these folks that they had found, but they still had intellectual disability. And this was treating older kids, folks that they had identified clinically. They did have, late in the 50s, 3 kids who had been treated from less than a month of age, and they all had normal development at 1, 3, and 4 years of age. These are probably 3 of the most important infants and toddlers in the history of man and certainly in the history of newborn screening. Because of these kids, that was what led to the institution of newborn screening, because we now had a treatable disorder. The unfortunate thing is that that treatment was only possible, that early treatment was only possible because there was a previous child in the family with PKU. You weren't going to find these kids and treat them early unless you knew to test the family. And so you had to test everybody. When they first started trying to test, they actually did it on urine. They were doing the ferric chloride test to find the phenylketones, and later this was kind of automated into a dipstick that you just dipped into the urine. The problem is that the urine typically isn't positive until the kid's 3 or 4 weeks of age. There are changes in metabolism that happen in those first few weeks, and new babies have very dilute urine, and so it might be below the level of sensitivity. The urine isn't always positive in PKU, and some babies just aren't ever going to show up for that test, or they're not going to have urine at the right time, and it might be weeks before or even months before you can get a urine out of the baby. So along came Robert Guthrie, and this shows him being a good scientist and actually enjoying free time as well. This was when he was visiting somebody in New Zealand. And he was trying to make a test to monitor PKU. And so he had blood collected on filtered paper. My guess is that he must have been a microbiologist because he used a microbiologic method. And so he had this bacillus that when you made an agar plate with this compound here, the bacteria wouldn't grow unless there was phenylalanine added. And what would happen is you would put these individual blood spots, and you'd have a row of standards, so you'd know about how much phenylalanine was in each blood spot, and then you'd have baby samples that you'd put next to it. And the plate, you'd let the plate grow for a while, and what would happen is you would get areas of clearing in your plate that indicated how much phenylalanine was there. And these were our standards of 0, 2, 4, and 8 milligrams per deciliter, and you can see that these samples had very low. This one's a little bit more, and then this one has quite a bit. They did actually do a pilot study, and unlike pilot studies now, they didn't identify any kid with PKU. They tested 600 kids, almost 700. Most of these were 4 days old because that's when babies went home from the hospital at that point. 8% of the results were greater than 2. So 1 in 12 kids had a number that was somewhat elevated, and none of the kids, there were very few that had results greater than 4. And so they said, well, let's say if it's positive, it's going to be greater than 6, and that's the kid you would test again. But nobody was positive in their group to know how low you had to be to identify PKU. McCready did. Based on some of the early studies, they actually did kind of this nationwide thing where they opened it to everybody. And there was supposed to be a ration of cards to different states, but McCready opened it up to all the hospitals in Massachusetts because he thought it was working so well. And over the course of about a year, they had tested 53,000 babies and identified 9 babies with PKU. Unfortunately, their report is just almost a note. And they didn't report kind of what their false positive and false negative rate was, but they didn't have tons and tons of false positives where the kids had a higher phenylalanine. So this was a good start on things. We had a method that worked. We could identify these kids, and then we could go ahead and treat them. There are some limitations, though. This is a semi-quantitative test. It requires a couple of days to get those bacteria to grow, and sometimes you would have a result that would come back even a little bit later because once it grew a little bit longer, they could see a little more more positive result there. It's a manual process, and initially they suggested that a technician could do 100 samples a day. In a state where it has a small state, say like Connecticut or Massachusetts, where they have 50 or 70,000 samples, babies born a year, you're looking at needing several hundred technologists to do the test. The baby needs to be feeding well so that the phenylalanine is high enough that you're going to detect this. Eventually, they could figure out they could do this for other amino acids, but you need to do a separate plate for every single amino acid. And you couldn't do the test for most amino acids. There was only very specific amino acids you could do it for. Despite all that, newborn screening, since you've already got the system in place, you've got samples coming in, they would kind of add new tests when they thought they were going to be helpful. And by about the 90s, you had tests being done for PKU with phenylalanine, for maple syrup urine disease with leucine, and homocystinuria with methionine. Those were all bacterial inhibition, and eventually some switched to fluorescent. They had tests for galactosemia, biotinidase deficiency, which is a vitamin recycling disorder, congenital hypothyroidism, congenital adrenal hypoplasia, which is a disorder of steroid hormone synthesis, cystic fibrosis, hemoglobinopathies, a number of different disorders had been added to newborn screening. And what ended up happening was by about 1990, you had this hodgepodge where some states would only test for one disorder. Other states were testing for as many as 6, and other states had legislated only a few, but were doing screening studies for many more disorders. And that included, let's see if I can find it in my geography here, North Carolina, who was doing a pilot study. We're getting ready to do a pilot study. But at 1990, what was happening is that already there were biochemical geneticists using fast atom bombardment mass spectrometry to look at metabolites in blood to identify different disorders. And so they suggested that maybe you could do this in babies and use it for newborn screening. And there were studies that came out that said, yes, we can do it, and we can can identify kids with PKU, we can use other factors. So there are a lot of advantages for why you might find it helpful. Certainly it's a fast analysis. For these metabolites, it was going to be a lot faster than a Guthrie. It was quantitative within the limits of the blood spot sample. It was multiplex. You could do all of the amino acids with just one analysis. And that allowed you more analytes than previous testing, and you could measure more specific markers than what they were using. They later found that analyte ratios increased the specificity, and if they had an abnormal result on an initial test, they could then go back and reanalyze that sample for something else and be more specific and in what was called the second-tier testing. Newborn screening has a lot of challenges that it presents to mass spectrometry. One is a small sample size. On that whole newborn screening card is maybe 200 microliters of blood, which seems like a lot, but it's whole blood. And within that 1/8 inch punch that you punch out of the card, typically for analysis, is 3 microliters of blood. You're restricted to blood testing because almost nobody does urine testing anymore except for one province in Canada. You do need high throughput because you're looking at anywhere from 50 to several million babies being born a year in different states. Some states have very low volumes, and so they were not going to necessarily be able to use this. And you also have within that sample a variable plasma volume. The hematocrit in a newborn can be anywhere from 20 to 70, and the rest of the blood is the plasma. And so what you're measuring is whole blood. You didn't have a way to adjust for how that sample was blood cells. By the same token, mass spectrometry had some challenges for the newborn screening system, primarily being instrument cost. You're looking at $250,000 per instrument, and you couldn't have just one. You were going to need to have a second for a backup because you couldn't not screen just because your instrument was down or needed maintenance. If you had a small state and only had 7,000 births a year, there's no way on earth you were going to afford this system. You were going to have to go with another system. Staff training was a big issue. A lot of these folks were medical technologists who had never seen a mass spectrometer in their life. They didn't even know what it did. And you weren't going to be able to kind of fire out these folks and say, oh, we don't need you anymore. You had to retrain them to be able to use these instruments. If you're doing multiplex testing, you have the chance that you're going to increase dramatically the number of false positives. And every time you call a baby in, that family gets very anxious. So you need to be able to do a good analysis without having a positive test on almost every sample, which could happen if you were going to start multiplexing. The instruments we're talking about are triple quadrupole instruments. This is a flow injection analysis with no chromatography. There are stable isotope labeled internal standards for many of the compounds, but there are some compounds that you just can't buy the standards for, and so people use it sort of as a ratio. And typically what you're doing is a butylated blood spot extract. And for amino acids, you can look for the neutral loss of 102. And for acylcarnitines, you're looking at the parents of 85. And for anybody who's forgotten their biochemistry, the acylcarnitines are what happens when the fatty acid groups get from the cytoplasm and have to get into the mitochondria. And they initially get transferred to carnitine, which then the acylcarnitine crosses into the mitochondria. And once you get into the mitochondria, CoA then picks up the acyl group, and carnitine can get back transported. And if you've got a block in metabolism of this compound here, of whatever chain link it is, then it can back up the whole system, and so you end up with a lot of extra acylcarnitine, not only in the cytoplasm, but ending up in the blood. This spectrum over here shows the parents of 85 from about, it was 200 to about 550. And in this case, the internal standards are C2, C8, and C16 deuterated internal standards. And most of the compounds you see are free carnitine, and you're seeing some acetylcarnitine. In the case of an abnormal, you can see clearly here that the C8 carnitine is elevated, along with the C6 and the C10-1, which are much higher than we're seeing in this sample. And this is a child with a medium-chain fatty acid oxidation disorder. Without identification, this kid might have had hypoglycemia or could have even died before having, without having any other symptoms prior to that. So the acylcarnitines were handy, but with that hodgepodge, some places were adopting this testing, some weren't. And in the mid-2000s, the American College of Medical Genetics made the recommendation that we have a uniform panel of newborn screening disorders that everybody gets tested for, that included 8 organic acidemias, testing for smaller, shorter chain acylcarnitines, 5 carnitine and fatty acid disorders, 6 different amino acid disorders, some hemoglobinopathies, and several other disorders, which a lot of places were already screening for. And so what happened is by 2010, we actually had a relatively homogeneous mixture where most states were at least testing for the ACMG recommendations, but then there are still some states that test for a few others. Some of these states either had mandated or were testing for a group of disorders known as lysosomal storage disorders. These are not mandated screening yet, but folks are trying to get them added. In this case, the lysosome is where it's kind of the recycling center of the cell, and these disorders are due to deficiencies of a single lysosomal enzyme. And depending on the enzyme that's missing, you may accumulate glycosaminoglycans or mucopolysaccharides. You might accumulate glycolipids. It might be lysosomal glycogen. These accumulating materials end up affecting the signaling cascades in autophagy, and there is some enzyme therapy for several of these disorders, which is part of what prompted the need for early screening. The symptoms actually depend on what material is being stored, and a lot of times, most of the time these kids are born, they have normal early development, and later they start losing developmental milestones. You can see bone and joint changes with a claw ham deformity if it's one of the disorders that affects the bone. Some will have cataract or corneal clouding. We see enlarged liver and spleen in many of these disorders. Some folks will have kidney failure in early adulthood. Some folks will have strokes in their mid-adulthood. The screening for these disorders is multiplexed enzyme assays. Some use a fluorescent substrate, and others are using mass spectrometry based. The problem is these are all overnight incubations. And so if you've got a plate of samples from that group of babies, it's very hard to multiplex this with the other analyses because you're going to have analyzed that plate already. And so you've got to have one plate where you're analyzing the small molecules, and then you've got the plate ready the next day for the enzyme assays. And so you potentially end up needing 2 different plates for one set of samples. The other problem with these is that it may identify the severe form of these disorders where the brain is affected and enzyme therapy doesn't help that. And it might also identify late onset forms where folks don't have symptoms until middle adulthood. And we don't know when you need to start enzyme treatment on those folks. So this is probably coming if it's not already in a state near you, but it's not necessarily ready for prime time. There are a few other challenges that we have that continue to be issues. One is that this is flow injection, so there's no separation of isomers. And this is a real problem with glutaric acidemia type 1, where the butylated mass for transition for gluteryl carnitine of 388 to 85 is exactly the same as what it is for hydroxydecanoyl carnitine. And so one way you could get around that is to run it underivatized, but that decreases sensitivity. Or you could use a different transition. This is one thing that's potentially fixed, but the system hasn't quite caught up with that. Another area where that's an issue, and we definitely don't have a fix yet, is in maple syrup urine disease. Typically now we're monitoring leucine and baleen, but these are amino acids that are both increased by a number of factors, including time of feeding, whether or not a child is on parenteral nutrition, and getting a large amount of these essential amino acids. And even though we say leucine, what you're actually picking up is leucine and isoleucine, which we know about, hydroxyproline, and alloisoleucine, which isn't quite a mirror image of the isoleucine. One carbon has the same stereoisomer of isoleucine, but the other is the opposite. And this is a compound which is increased specifically in maple syrup urine disease. It'd be great to be able to measure that compound instead of just straight leucine, but we don't have a way to do that under current technology. We also have conditions where the most specific marker isn't easily measured. Things like homocystinuria, where the homocysteine is bound to protein. And since it's not extracted, we end up having to measure methionine instead. Sometimes one compound is actually a marker in several different conditions, some of which are not diseases. And that's a problem that can't get fixed by mass spectrometry or better chromatography. It's just something we have to deal with as part of the system and figure out, is it worth it to pick up those kids who don't have disease and to find the ones who do. It might be that we could find a better marker with metabolomic studies of kids who have these disorders. There are false negatives, which we have to try to minimize, and identifying folks who don't have disease. And some of the current research is trying to figure out who actually has disease, who has symptoms, despite having high concentrations of some of these markers. One disorder that we thought was very rare, methylcrotonyl-CoA carboxylase deficiency, is actually one of the most common disorders, and we didn't find it until we started finding it in the mothers of babies with positive screens. Metabolites can normalize by the time kids come in for their diagnostic testing. We're getting these newborn samples in the first day or two of age, where kids are very stressed by being born, by the fact that they may not be getting very much. They haven't figured out quite how to suck and drink, or the breast milk might not be in. And so when we get them to clinic, even if it's 4 or 5 days later, their metabolites have normalized. And so then we need a better test to be able to identify those kids. Some kids are going to be symptomatic before the screening results are available. And that's a situation where we could say, well, you know what, we don't need to screen for those kids. We know that they have symptoms and disease. The problem is they might get born someplace where people don't know quite what those symptoms are and what they mean and how to test, even with the chemistry tests that they have available to them. A big problem is that there is no mass spec training in medical technologist programs. And so anybody coming into the screening labs, and in some places they need to be medical technology trained and certified, is not going to have been exposed to any of this. It's a completely different area that they're going to be looking at. So what's the future going to be in newborn screening? And there's a big question mark here. I couldn't quite make it big enough to get everything else on. But in terms of small molecules, we could add new disorders, things where there are significant health issues, but we may not even know quite what those disorders are yet. We could take the enzyme assays that are being done on other platforms and turn them into mass spec-based methods. If we use chromatography, whether it's either some sort of fast chromatography or multiplexing, we might be able to do something that will separate out things like the leucines and give us the kid who has alloisoleucine, even though their leucine, total leucine might be down in the normal range. We could start looking at macromolecules. Just last month in the February Clinical Chemistry was an article using mass spectrometry with hemoglobinopathies to identify just the baby who has sickle cell disease and not the kids who have sickle trait. Those kids with sickle trait, for the most part, will never have symptoms, so we don't really want to identify them. We don't want their parents to worry about them. But at the same time, we've got to be sure we get the kids who will sickle and who will have symptoms. The lysosomal storage diseases are probably going to happen no matter what we do. And in the future, there's going to be a lot more DNA tests happening. Already, whole exome sequencing has been suggested to identify every single variant that's in a baby. That's going to pull up a lot of variants. We're not going to know what they are. And one way we may have to confirm those as pathogenic would be to look at metabolites that might be consistent with that diagnosis. FDA regulations on lab-developed tests is going to be a big issue. They're now changing how, or they're thinking of changing how instrument manufacturers and companies who make research use only kits can interact with clinicians. And if you don't have a good reason, like having an FDA-approved test, then you can't interact with these folks and give them hints on how to set these up. A lot of states would not have been able to do newborn screening without the support of the instrument manufacturer. And we may find that this is going to restrict future testing, especially if new test modalities are being used. We've looked at kind of some of the applications of newborn screening. It's probably the most frequently used application of mass spectrometry in the clinical lab. It definitely has expanded the newborn screening capabilities. The current mass spec testing could be expanded, and it could be modified for better identification of some disorders and maybe even identification of other disorders that we're not currently testing for. Adding new disorders may end up changing either the number of instruments that we need to screen a certain number of babies, or it may mean we need to use different types of mass spectrometers. This has always been a triple quad world, but maybe we need to be using something different to more fully evaluate the different options that are there. And the FDA may affect future newborn screening development, hopefully not so much. But with that, thank you. This 5-month-old baby has citrullinemia type 1. Her development is normal so far, but without expanded newborn screening, she either could have died or had significant developmental handicaps because of the fact that she would not have been identified until she ended up in coma. So she and the rest of the families who have been affected by newborn screening, I think, definitely help folks who have moved this into the 21st century and made it available clinically. Any question?
So we got a few questions. Yes, in the back.
So what concentrations of phenylalanine or isoleucine?
So I think the question was, what concentrations of phenylalanine are you talking about there?
Isoleucine, whatever amino acids you're looking at.
What's the normal range for amino acid concentration that you're detecting in these patients versus an abnormal?
Is it micromolar?
Yeah, it's micromolar for the most part. For leucine, you're looking at about 100 micromolar is normal. In folks with MSUD, that's for leucine alone though, but once you start adding the isoleucine and the hydroxyproline, you're up at a couple hundred. If it's now the normal amount that's there, and then the child is getting IV nutrition with high concentrations of those amino acids, that adds in maybe several hundred more. And so those kids could actually have up to 1,000 micromolar leucine by the newborn screening test, and yet will never get sick. Whereas the child who has MSUD may only have a couple hundred micromolar leucine, but a big part of that is the alloisoleucine, which is a very specific marker.
So did you think of capillary electrophoresis for amino acid identifications?
Did you think of capillary electrophoresis for this sort of application, for cleaning or separation?
Because of the number of samples, typically this has been tried to be a very fast. These samples are injected at 1-minute intervals. So to do that many samples and to be able to get all of the amino acids, the acylcarnitines, and all the other metabolites that you want to get in that 1 minute in a system that is usable by folks who aren't used to this kind of technology, it's either probably going to be either a flow injection or a fast LC that's going to do it. I don't think they'd be able to. There are people use LC as a second tier test, and then they'll go through and check the kid who's high on leucine initially. But to get to that kid who's high, you really have to pull down your number and say, okay, we're going to test everybody who's over 300, and that ends up being a lot of kids to test. Then you run out of instrument time because you've got already so many newborns getting their first test done or their second test done because something showed up on the first sample. So you can do them by a lot of different methods. It's just the volume of samples that you've got and what the people who are running the instruments will be able to do.
For the reference, how many tests do you perform in your lab a year for newborn screening?
I'm not a newborn screening person, so I don't do any in my lab. In our newborn screening lab, they do actually 5 New England states and do somewhere about 100 or 120,000 samples per year. And that's a small group. I think they have 3 or 4 triple quads to do that.
3 or 4 triple quads do that.
Because you always got to have one for backup, they have one for development. They've got one for second tier now